Hey guys, it is Miss Hill here, and I am going to record you guys a lecture on individual module 5.3. We'll be talking about the concept of reproduction and mood and affect, specifically related to postpartum care and postpartum depression. So this lecture is being recorded in fall of 2020, just so you have a reference. All right, so we just skipped over our learning objectives. You guys can look at those on your PowerPoint. And the first thing that we're going to talk about is postpartum care. There are several key terms that you need to be aware of whenever we talk about postpartum care. And we're just going to go down the list here and talk about some of these. Involution, you should remember from our postpartum assessment day. So involution is how the uterus goes back down to its normal size after delivery, and that happens over several weeks. Subinvolution is the opposite of involution, and if a patient has or is experiencing subinvolution, that means there is a problem. The uterus is not descending as it should be in the abdomen. So you're going to find a discrepancy in your assessment. The fundus is just the top of the uterus. Lochia, we have three types. We have rubra, serosa, and alba. Uterine atony is just a term for what happens when your uterus does not contract in the postpartum period. It becomes atonous. It is boggy, and that will put your patient at risk for postpartum hemorrhage. Diastasis recti abdominis is a problem that you might be able to assess in the postpartum period related to the woman's musculoskeletal system. If you remember, we talked about this in the antepartum period, and this can be a change that happens in the musculoskeletal system of a pregnant woman where her abdominal muscles sort of separate down the center. Colostrum is that first bit of milk that mothers have. You usually see it around between 1 and 3 days after delivery. Transitional milk comes in after that, and then by about 2 weeks' time of breastfeeding, your mom has what we consider mature milk. Oops. All right, so an overview of what the puerperium stands for. This is just the nursery word for the postpartum period. It begins immediately after birth, and it continues for approximately 6 weeks. This is the time whenever your mom is readjusting physically. Her body is trying to get back to its normal state. She is also having some psychological changes that are happening in this postpartum period from pregnancy and birth. And we'll talk about some of those, like maternal adaptive behaviors and those types of things. Several physical adaptations happen in the postpartum period. There are a lot of physiologic changes of pregnancy. As you know, we talked about a number of those in our antepartum care lectures, and they happen over several months. But after delivery, the mom's body will go through changes to get back to that non-pregnant state. Involution is one of those changes that happen in the reproductive system. So There are changes in the uterus. There is a rapid reduction in size of the uterus as it returns back to its non-pregnant state. The bleeding of the postpartum period is controlled specifically by the compression of muscle fibers within the uterus. The placental site in the uterus takes about 6 weeks to heal over. And we also have some hormonal changes that happen at this time. So there is a decrease in levels of estrogen and progesterone, which causes an atrophy of the uterine cells. And this helps to reverse the hyperplasia of pregnancy. So the growth of the uterus, we're reversing that with these decreased levels of hormones. The top of the fundus will descend into the mom's pelvis by about the 10th day post-delivery. And if you have a mom who's breastfeeding, that will actually quicken this process of involution. The uterus will approach its pre-pregnant size at around 5 to 6 weeks. And you should know that your mom can also experience what we call after pains. And those are just basically cramps that are caused by the intermittent contractions that happen in the uterus after childbirth. Those contractions are good things because we want those contractions to control the bleeding postpartally. These birth after pains are much more severe in multiparas. Moms who have delivered macrosomic babies, women who are breastfeeding, and women who are receiving oxytocics. So breastfeeding causes after pains because moms who breastfeed, when they are in the process of doing that breastfeeding, their brain will release the hormone oxytocin, and oxytocin will cause your uterus to contract. So that is why the after pains are worse for breastfeeders, and they will notice those pains happen as they are breastfeeding. The uterus is going to shrink in size and weight and from around 2.2 pounds back down to about less than 2 ounces. And remember that your umbilicus is the reference point for that. The fundus should be at you immediately after delivery, and it should remain in the midline. It will descend every 24 hours by about 1 to 2 centimeters or a finger breadth. The cervix at this time is flabby and slit-like, and it will later firm up and elongate. Moms who are experiencing those after pains from breastfeeding, it is important to educate them that those after pains are only going to last a few days, and that will help encourage her to continue to breastfeed. Some women feel very discouraged and they're overwhelmed that every time they breastfeed their stomach starts to hurt, but it's important for you to educate them that those after pains will subside after a few days so that they don't give up on breastfeeding. Lochia is another thing that we have to talk about whenever we talk about changes that happen in the postpartum period. So lochia is just the discharge that happens from the uterus, and it is just basically clearing that debris that remains after childbirth. There are 3 different types. We have lochia rubra, which is dark red, and you see that during the first few days after delivery, usually kind of 0 to 3 days postpartum. And you may see some small clots with lochia rubra, and that is okay. We just watch those people a little closer. Lochia serosa is more of a pinkish color, and we see that anywhere from days 3 to 10. Lochia alba is more of a creamy or a yellowish tinted discharge, and that usually continues to occur for about 1 to 2 weeks after that 3 to 10 days of serosa. Lochia patterns vary individually. So none of your patients will really experience the same thing, but in general, we know that lochia trends toward a lighter color and a lighter flow. If your mom experiences the opposite of that, that would be a concern that would need to be reported. When lochia stops, the cervix is considered to be closed. It usually has a musty and a stale odor, but it is not offensive. If there is an offensive smell to a woman's lochia, so it is foul smelling, that could indicate that there might be an infection, and that needs to be assessed. Usually the total volume of lochia is going to range somewhere around 225 milliliters. Lochia will be greater in the morning, and it may increase with breastfeeding moms. So they should know that as they breastfeed, they may actually feel themselves discharge some lochia during that breastfeeding, and it all has to do with that oxytocin release from the brain and the cramping down of the uterus. It is very necessary, obviously, to assess your postpartum woman for hemorrhage and to assess her uterine involution to be sure that things are going like they should be. We describe lochia in a few different terms, so we can either chart it as scant, light, moderate, heavy, or excessive. If your mom is having heavy lochia, she is saturating a pad from front to back in about 2 hours, and that's okay, but we just need to keep a really close eye on her and ensure that the lochia that we're seeing is an appropriate coca, and rule out any other problems. An excessive amount of lochia is going to include something like saturating a pad from front to back in less than an hour or in around 15 minutes. That's too much. Other abnormal things that you might see from a lochia standpoint are going to be things like large clots, a foul odor, again, an excessive amount. If the mom continues to have rubra past 3 days, that could mean that she has some retained products of conception and put her at risk for a possible late postpartum hemorrhage. If the mom has an extended days of serosa or alba, that could possibly indicate endometriitis, so an infection of the endometrium. If the mom has a return of rubra with signs and symptoms of infection, then we are definitely going to be worried about that mom. She would need to come back, she would need to be seen, and she needs to know to report that. If she moves through these stages towards a lighter color and a lighter flow, and then all of a sudden her rubra comes back, that's a problem. So there are several cervical changes that also happen in the reproductive system from a postpartum standpoint. Following birth, the cervix is very flabby and formless, and you can get usually about 2 fingertips into the end of the cervix for a few days after birth. But by the end of the first week, you should only be able to get 1 fingertip into the end of the cervix. And the process of childbearing, the process of labor and delivery will permanently shape the external os of the cervix. From a vaginal standpoint, you may see that the vaginal tissues appear very edematous. They may look bruised following birth. You will find that The size will decrease and rugae will start to return in about 3 to 4 weeks. By 6 weeks, the vagina should appear to be normal, back to its normal state. And teaching your mom about Kegel exercises is also very important because during the antepartum period, carrying all of that weight on those pelvic floor muscles and tissues can interfere with the tone of those. So doing Kegel exercise will help to improve the tone and the contractility in the perineal area. It'll help the mom to keep from peeing on herself whenever she exercises or sneezes or coughs. So it's important for her to know how to do those. From a perineal standpoint, the soft tissues can be edematous or bruised. If the mom has an episiotomy or a laceration, it is important to make sure you're assessing that the edges are approximated and looking for signs of Rita. So redness, edema, ecchymosis, discharge, and approximation. We're always checking for the episiotomy, any tearing, any hematoma formation, any hemorrhoids, and the initial healing of the episiotomy or a laceration should usually happen within the first 2 to 3 weeks after birth, but it might take anywhere for up to 4 to 6 months for it to completely heal up. And during that time, moms may experience a lot of perineal discomfort, particularly when it comes to sexual relations or intercourse. Things may be very uncomfortable during that healing time, and sometimes even after. So that is an assessment question that you would want to ask to a mom who is postpartum if you're seeing her and she's had some perineal issues such as an episiotomy or a laceration. And it's also important to be looking in the perineal area and making sure that there are no solid masses, or that your mom is not having complaints of perineal pressure or pain, because that could indicate that she has a hematoma. Up to 400 milliliters of blood can collect in the vagina, and at 500 milliliters lost, you're going to start seeing signs and symptoms of hypovolemic shock in your patient. If your patient has had an epidural, they might not experience any pain or pressure, so they might not complain of that. And vital signs are going to be your first clue there in those patients. If there is a large hematoma, it might require surgery. And if there is severe hypovolemic shock, then it is going to be imperative to stop that bleeding, and that might have to be with surgery. Ovulation and menstruation in postpartum women will usually sort of get back on track around 7 to 12 weeks after giving birth in moms who are not breastfeeding. For moms who do breastfeed, ovulation and menstruation can take anywhere to up to 3 years to come back. It is associated in breastfeeding moms with the length of time that she breastfeeds and whether or not she supplements that breastfeeding with formula or other foods. Exclusive breastfeeding will delay menstruation by greater than or equal to 3 months, and can help reduce the risk of pregnancy, but it's not a reliable means of contraception, so your moms may need something additional if they are not planning to get pregnant. In the abdomen, during the antepartum period, the uterine ligaments have become very stretched and they require a lot of time to recover. So you're going to see a stretched abdominal wall, and typically that stretching will respond fairly well to exercise within about 2 to 3 months. The abdomen still may remain a little flabby, particularly in women who have had several babies and women who have an overdistended abdomen anyway. If the woman has had poor muscle tone before pregnancy, so she was not very active and did not have a really toned abs before pregnancy, it might not firm up quite as well. It might remain flabby. Women with diastasis recti abdominis, or separation of the abdominal muscles, also can do exercises to help that condition. It can be more pronounced in women who have undergone cesarean delivery. And again, that's a condition that occurs with pregnancy during the antepartum period. It's part of those musculoskeletal changes that you might see. Stretch marks are another one of those changes that we see in the integumentary system, and they will gradually fade, but they will never completely go away. They're always going to be visible. Another thing that you might see in the abdomen are C-section incisions. So we want to know what type of incision that there might be. That may be something else that you have to assess. And then also bowel sounds, particularly if we're talking about a patient who is a C-section. We're going to want to be listening for those in all 4 quadrants. So, breasts and lactogenesis. During pregnancy, there are some increased levels of estrogen that will stimulate the breasts to proliferate ducts and develop those milk ducts in preparation for breastfeeding and lactogenesis. Elevated progesterone levels will promote development of lobules and alveoli. Prolactin levels will also rise during pregnancy, but the lactation itself is suppressed by the elevated progesterone. Now remember that progesterone is our pregnancy hormone, and our uterus, our placenta, is what is secreting progesterone during pregnancy. So that high level of progesterone during pregnancy is actually keeping breast milk production, basically, and lactation from happening. But when the progesterone levels fall, once the placenta is expelled, we remove that inhibition system and milk production is triggered. So that is why women start to see milk after the placenta is delivered, or after delivery of the baby. Lactation is initially under an endocrine control. If there is an inadequate development of prolactin receptors, however, that will have a negative effect on how much milk a mom can make. There are a couple of different types of milk that we need to talk about whenever we talk about breastfeeding, and those are foremilk and hindmilk. So foremilk is the milk that will flow from the breast at the beginning of a breastfeeding or a pumping session. It is really high in protein and it's very low in fat. So think of foremilk kind of like skim milk almost. Hind milk, however, is milk that flows during letdown or after the milk ejection reflex. It is really rich in fat and it's very high in calories. So when teaching a mom how to breastfeed, it's really important that she understands that she needs to feed her baby and completely empty the breast, because we want the baby to get the fore milk and the hind milk. If a baby is drinking only the fore milk and then the mom switches that baby to the other breast and it only gets the fore milk from the other breast, those babies are going to tend to be probably a little more gassy. They will tend to be a little more hungry, and the mom will also not be emptying out her breasts as well. So that's going to inhibit her milk production. And speaking of inhibiting milk production, lactogenesis works off of this inhibition system. So specifically, it is the feedback inhibitor of lactation. And basically what this means is that there is just a negative feedback loop that happens with milk production and breastfeeding. The more milk that remains in the mom's breast for longer periods of time, the more that the body will decrease milk production, because there's still milk in the breast. So if there are milk left in the breast, the body doesn't think it doesn't think that it needs to make any more, so it won't. But if the breasts are emptied often and fully, then there's a lower level of that feedback inhibitor of lactation, and the faster milk will be produced. This process is an autocrine control process, and it is the key to understanding how a mom will keep her milk production up, and it's key for her to understand that so that she doesn't lose her supply. There are several factors that can impair lactogenesis in a postpartum mom, and those things include C-sections, hemorrhages, and if you think about those two, we're losing a lot of blood, so the moms could be dehydrated, and they just have a severe volume loss, which can affect the amount that is made. Women with type 1 diabetes, hypothyroidism issues, obesity, polycystic ovarian syndrome, all things that have to do with hormones. If moms have retained placenta fragments, that can impair lactogenesis, because we still have that placenta retained and it is continuing to produce progesterone, which will inhibit this process. Moms who've had breast surgery or who have insufficient glandular breast tissue. So this does not mean that the mom has small breasts. It just means that she does not have sufficient amount of glands to be able to create milk. So it doesn't have to do with the size of your breast, but the glands and the ducts themselves. Moms who are under a significant amount of stress will also have problems with making milk and keeping their supply up. And also moms who are smokers or they use alcohol, specific types of prescription drugs. There are medications that we can give to moms to help them increase their breast milk supply. One of those specifically is Reglan. It's sort of an off-label use, and it can help increase milk supply. And here are the stages of human milk. So initially we have colostrum, and that is immediately available to the baby at birth. It gives them all the nutrition that they need, and until the mom's milk becomes more abundant. But it is packed full of antioxidants and plenty of nutrients for the baby. We then will have transitional milk, and that usually occurs after about 30 to 72 hours of colostrum production. It is in a better supply than colostrum, so there is more of this transitional milk than what you can get of colostrum, and it will contain more fat and lactose and water-soluble vitamins and calories. And then by about 2 weeks postpartum, your mom starts to see what mature milk is going to look like. And it is very watery. It's about 87% water. And then it contains the rest of that is carbohydrates, proteins, and fats. So what we consider your solids. Those are your building blocks, all your nutrients. And despite the fact that it's a very thin in appearance, it will provide the baby with everything that they need from a nutrient standpoint. You might encounter several breast problems in the postpartum period, specifically engorgement, mastitis, and cracked nipples can be some of those. So engorgement happens because somehow the lymphatic circulation becomes blocked and the veins become congested and milk is not able to flow through like it's supposed to. You will get an area that is nice and red and swollen. It will be very painful to the touch. For moms who are breastfeeding, they need to use warm compresses, pump, feed off of that side, massage the area when they're pumping and feeding until they can, until it's able to be let down. The milk is let out. Mastitis can happen as well, and that just means there is an infection in the breast tissue. Moms with mastitis will end up with flu-like symptoms. It is very, very painful. They'll have body aches. They'll have a fever. They will feel like they're about to die. It is terrible, and they will need some antibiotics for sure. Cracked nipples are another thing that we might see with moms, particularly if the baby is not latching appropriately, and then this can be a portal of entry for infection for things like mastitis. So we want to try and head those problems off if we can. So ways that we can prevent some of these problems is by encouraging and teaching mom to wash their hands, to breastfeed their babies on demand, which just means when they get hungry, when they're ready to eat, feed them. Don't try to put them on a schedule. Don't try to wait and feed them every 4 hours. If they're acting hungry, go ahead and feed them. That's sort of how engorgement can happen if we're trying to put babies on a schedule or we're waiting long periods of time between feedings. It can cause engorgement. Also, correct breastfeeding techniques are important, so making sure that the baby is able to latch appropriately, get a correct latch on. The baby should have his or her head tilted up. The lips should be flanged out, and the mouth should cover the areola. The baby should never be sucking on just the mom's nipple. Moms should also wear a snug and tight-fitting support bra to help support her breasts as well. From a GI standpoint, after delivery, moms are going to be very hungry and very thirsty. It is important for them to drink plenty of fluids to replace what they lost during labor. They will also be having a lot of diuresis. So again, very important for them to keep themselves hydrated. Bowels tend to be very sluggish after birth, and it can be for a number of reasons. So there can be this lingering effect of progesterone. They also have decreased abdominal muscle tone just because of carrying this pregnancy for 9 months. And evacuation of their bowels can also happen during the labor and delivery process. So they may have already, been to the bathroom. Women who have episiotomies and lacerations or hemorrhoids might try to delay having a bowel movement because they are afraid that it's going to hurt or that it might tear their stitches open. And if they refuse or delay their bowel movements, that can increase their constipation and it can increase their pain, particularly for women who have C-sections as well. So there is no evidence that suggests we should actually restrict oral intake in individuals who have had those C-sections. So it is often very safe to put them on a regular diet directly after after they've had a C-section. Of course, we would want to be listening to bowel sounds and making sure that they had bowel sounds before we would do that. C-section moms also will have some initial discomfort because of gas buildup in their abdomen. We got to remember that they've been cut open. They've had a major abdominal surgery. So once they're closed back up, the air that is still in their abdomen has to go somewhere. And one way to relieve the pain from gas for your C-section patients is to get them up and get them ambulating early. We also use simethicone or an anti-flatulent medication. Chamomile tea and peppermint tea can be some of your other complementary alternative medicines to use for these people. And stool softeners are often very helpful for people who have delivered vaginally or by C-section. Make sure that obviously that you are assessing bowel sounds for these patients, and not just the C-section patients, but make sure that you're also evaluating bowel sounds for your vaginal deliveries, particularly if they have had some type of intervention during the delivery process, such as a use of forceps or a vacuum, to help get that baby out during the second stage. A postpartum woman has a very increased bladder capacity, and she may have some swelling and bruising of the tissue around her urethra because of the trauma of the fetal descent through the pelvis. It is possible for those structures to become damaged or bruised. She's going to have a decreased sensitivity to fluid pressure because of this increased bladder capacity, and she will have a decreased sensation of bladder feeling. So she will not recognize that her bladder is getting full. And it's important for you as the nurse to be assessing her bladder for distension so that we can avoid any problems that might happen with too much urinary retention. Pretty much every patient who has had a labor and delivery gets some type of oxytocin, and oxytocin has an antidiuretic effect. So most women get this in the postpartum period, and a lot of women get this during the intrapartum period just as an augmentation or if their labor is being induced. So after we stop oxytocin, because it has this antidiuretic effect, once we stop that, that woman is going to experience a really rapid bladder filling. And if that's coupled with the fact that she doesn't really sense that her bladder is filling up, and the fact that her bladder has an increased capacity to hold urine, remember our baby's not there anymore, taking up room, so now our bladder can expand very well, we could run into problems with urinary retention. The postpartum woman's urinary output is going to increase tremendously during the postpartum period because of puerperal diuresis. their kidneys are going to put out somewhere between 2 and 3 liters of extracellular fluid after delivery. So it is very important that they are able to eliminate what is building up in the bladder. So this is an immediate concern in the postpartum period. Women who have urinary stasis are at chance for urinary tract infections. And then also, as the bladder starts to fill up, it will displace the uterus, interfere with its contractility, and then your mom now is at risk for a postpartum hemorrhage. If your mom is not able to void freely, if she cannot do it by herself, then it is important to do an in and out cath on her. These women might possibly need some bladder hygiene or some bladder training, particularly if they're having a lot of trouble with sensation. It is important to assess the coca of their first urine and be looking out for proteinuria and ketones in your patients who, are going to be having those, like your diabetics. So those patients can actually see this proteinuria and ketones from around still up to like 4 to 5 days postpartum because of the fat breakdown that is happening. Vital signs are something that you are going to see change in your postpartum woman. Oh, my computer shut by accident, so I was afraid I had lost you guys. All right, vital signs are something that we obviously should be assessing in our postpartum patient. The postpartum woman should be afebrile, except possibly during the first 24 hours after birth. So it is possible for your mom's temperature to be up to around 100.4 degrees in the first 24 hours after birth. And that just happens because of this massive exertion of the labor and delivery process, and then the dehydration that can happen to the mom because of the labor and delivery process. Temperatures might increase anywhere up to 102 degrees. And then immediately following childbirth, from a vital sign standpoint, you're going to see a transient rise in their systolic blood pressure and their diastolic blood pressure. And sometimes this abdominal engorgement that they experience can cause orthostatic hypotension in the first 48 hours. So we would be careful getting them up to the bathroom, and we would want to talk to them about making sure that they sit on the side of the bed before they get up. All those educational things that we do for people who might experience orthostatic hypotension. People who have low or decreasing blood pressure, that can be a late sign that there is some hypovolemia due to hemorrhage. So don't ever just depend on your blood pressure to tell you whether or not your mom is having some hypovolemia. You need to be assessing other areas and other things. Blood pressure elevations can happen because of excessive use of oxytocin or other types of vasopressor drugs. If your mom has had to receive ephedrine because of an epidural, if she has had to receive a lot of Pitocin to induce her labor for long periods of time or augment her labor, you might see blood pressure elevations. Partly some of that can be due to this antidiuretic effect of those oxytocin. Sorry y'all, I had to yawn. You also may see some bradycardia in the postpartum period, and that is common for the first 6 to 10 days after delivery. And in the immediate postpartum period, you might see your mom start to have what we call the labor shakes. And so you will see tremors in her body. And if that isn't followed by a fever, there is really no clinical concern for that. But you can offer some comforting measures for her, like a warm blanket or a warm beverage. That might help make her feel better. Also, do not forget to assess your mom's pain. Of course, we know that that is part of the vital, like our sixth vital sign. And so that is really important for your vaginal and your C-section deliveries. These patients are going to be so tired. They are going to be fatigued after labor. They're going to be extremely tired after this whole process. Your moms might complain of headaches if they've had a C-section or an episiotomy or a laceration. They may complain of pain in those areas related to those procedures or complications from delivery. And they may also complain of leg pain, particularly if they have had to push for a long time and they've had their legs in lithotomy position for an extended period of time. From a lab work standpoint, we should see our lab work return back to a pre-pregnant state by the end of the postpartum period. However, the incidence of thromboembolism still stays increased in our postpartum population, but the way that we can reduce this risk is by ambulating our patients early, and that is so important for our vaginal and our C-section deliveries. It is very common to see an increase in their white blood cell count. So you'll see this leukocytosis, but it is non-pathologic. It's not associated with infection. It is associated with the stress of the labor and delivery process. But if the patient does have an acute infection brewing, this leukocytosis process could actually sort of hinder being able to diagnose your patients early. So making sure that you're paying attention to things like fever or the smell of lochia or other signs and symptoms of infection are important. Hemoglobin and hematocrit levels can be very difficult to interpret during the first 2 days just because of all of the fluid shifting that happens. Platelet levels will typically fall as a result of placental separation, but they will start to increase back around days 3 to 4 postpartum, and they'll return to normal by about the 6th week. Fibrinolytic activity will return to normal in the first few hours following birth, and the hemostatic system as a whole should reach back to its pre-pregnant state by about 3 to 4 weeks. However, the diameter of the deep veins will take up to about 6 weeks to return back to normal, and because of this, that is why your patient remains at risk for these blood clots during the first 6 weeks after birth. So even though that our hemostatic system is getting back to a pre-pregnant state around 3 to 4 weeks, our deep veins remain sort of vasodilated, I guess, and that creates this risk of pulling of blood that can put your patient at risk for DVTs. If your mom's immune status for MMR is negative or equivocal, she is going to need the MMR vaccine before going home. And then, of course, another thing to think about from a lab standpoint are your Rh negative moms. So those mothers who are Rh negative are going to need RhoGAM within 72 hours if they have a baby who's positive. The cardiovascular system just has such drastic change that happens during the antepartum and the intrapartum period. There is this huge increase in cardiac output that can really put patients at risk for some cardiovascular instability, particularly if they already have cardiac issues to begin with. So from a cardiac output standpoint, your patient will usually stabilize and return back to their pre-pregnancy level within about an hour following birth. And this maternal hypervolemia that occurs during the antepartum period helps to protect your patient against excessive blood loss. So remember when we talked in the antepartum period about how we have this massive increase in plasma volume and red blood cells, and all of these things increase in the antepartum period. All of that helps protect your mom against what we know is going to happen during labor and delivery, which is blood loss. In the first couple of weeks, your patient's cardiac output is going to decrease by about 30%. And it will reach back down to its normal level by 6 to 12 weeks postpartum. And so one thing that really helps in cardiovascular or causes a lot of these cardiovascular changes in the immediate postpartum period is this puerperal diuresis, this postpartum diuresis that happens. So in the first 2 to 5 days after delivery, we have this massive decrease in extracellular fluid because your patient is peeing everything out. And that helps to reduce weight. And if your mom fails to do this diuresis, then that can cause pulmonary edema, or it can cause other cardiac problems. So for that patient, we're talking about how it's really important to make sure that your mom is able to pee after delivery, and how she's going to be putting out almost 2 to 3 liters in those first hours after delivery. If she fails to do that and she's retaining all of this and she's not peeing any of it out, then all of that can start backing up and causing pulmonary edema. So from the nursing standpoint, what you're going to be able to assess from a signs and symptoms standpoint is you're going to be able to start hearing crackles whenever you listen to lung sounds. And then for people who already have cardiovascular issues, this will just compound those problems for those people. So you would watch them extremely closely in this postpartum period. Also, this failure of diuresis to happen is more common in women who have a history of preeclampsia or pre-existing cardiac problems. So that would throw them over into a high-risk category, and you'd be watching them close. All right, so what about the neurologic and the immunologic systems? From a neurologic standpoint, women who already have some neurologic problems or disorders, so think things like epilepsy, they are already predisposed to have an increased risk for morbidity and mortality during pregnancy and the postpartum period. From a problematic standpoint, headaches are the most common thing that you are going to see from a neurologic symptom standpoint in postpartum women. And the reason that these headaches happen is because of fluid shifts during that first week after birth. If they've had a spinal, they might end up with some leakage of cerebral spinal fluid into their extradural space, and that is going to cause headaches for that mom. They are often very severe. It's hard for those moms to sit up. It's hard for them they're very light sensitive, and oftentimes medication is not very helpful for moms who have spinal headaches. They sometimes have to have something called a blood patch to help those spinal headaches, and that's basically where they have to come in and they have to have their own blood drawn, and then that blood is injected into and around the same place where their spinal was inserted, and the blood patch is supposed to sort of clot off that leak and even out the pressures, basically. Gestational hypertension can also be a reason why women are complaining of headaches. If your patient has that or has some preeclampsia, then we might be looking for headaches related to blood pressure issues. And then stress, just the stress of labor, the stress of delivery. Remember that your mom is pushed. If she's pushed for a really long period of time, that will increase your intracranial pressure. The stress of not sleeping, of having this whole new life that you have to get used to can cause stress headaches for people. Migraines might persist during pregnancy and during the postpartum period, so patients who have those may need to be managed carefully for those. Seizures are more likely to happen during labor or during the first 24 hours postpartum than during the pregnancy period. So for patients who are at risk for that, we'd be keep a very watchful eye on those people. Women who have epilepsy also may have more feeding difficulties. They may be more irritable. They may have some lethargy, and particularly if they have experienced seizures during this intrapartum or postpartum period. The initial weight loss that you will see in the postpartum period as a result of birth and the expulsion of the fetus and the placenta and the amniotic fluid is around 10 to 12 pounds. So that's a lot of weight to lose at one time. And then additionally, from actually diuresing, your mom is going to lose probably about an additional 5 pounds. So we're talking about anywhere from 15 to 17 pounds that your mom is going to lose in just the first few days postpartum. And many women are going to return back to their normal pre-pregnant weight by about 6 to 8 weeks postpartum. But there can be some nutritional needs that have to be addressed following childbirth, and that depends on whether or not the mom is going to breastfeed or if she's going to formula feed, and we'll talk about those on the next slide. But from a nutritional status standpoint, we can determine those needs by assessing the mom's weight, by assessing some of her labs like hemoglobin and hematocrit, clinical signs that are related to her nutrition, and then any dietary history information that we have or that we collect. The amount of weight gained during pregnancy is a major determinant of how much weight loss happens after childbirth. So women who gain an excessive amount of weight during pregnancy are more likely to keep that weight on, and they're more likely to be overweight and obese from a long-term standpoint. A mother's weight should be considered in terms of what their ideal weight is. what their pre-pregnancy weight is, and by the weight gain that happened during pregnancy. So in other words, what does the mom want to weigh? What did she weigh before she got pregnant? And how much did she gain during the antepartum period? And that is how we should help them from a nutritional standpoint. Hemoglobin and erythrocyte levels should return back to normal within somewhere between 2 to 6 weeks. So if the mom has had a postpartum hemorrhage, if she's had some pretty heavy bleeding, if her hemoglobin and hematocrit levels are low, then she might need to continue to take iron supplements after childbirth. And that could be something very important nutritionally that that mom might need. Constipation can be a real problem after childbirth, so encouraging women to maintain a really high fluid intake, particularly water, is important, and making sure that they understand what dietary sources of fiber are and how they can add those into their diet to help with constipation issues. Dietary assessments can really help in providing a mom with a nutritional plan, or helping her come up with a nutritional plan. We would never provide a nutritional plan to a mom that was all our own. We would want her input, and it would be something that you would help that mom plan out, but it would need to be something that she could take ownership of. So observing the mom during meal times, making sure to include cultural and religious beliefs are very important. Referring people who have an unusual eating habit or a whole lot of questions about nutrition to some type of dietary counseling or dietitian, and then providing literature on nutrition for them to take home, or showing videos, or just different types of ways to teach them. The risk for obesity during childbearing years can be let me rephrase that. It is important to use the postpartum period to help moms change behaviors. So moms who are pregnant and who are gaining a lot of weight over a short period of time can be at a greater risk for obesity just because of those antepartum changes that occur. And so during the postpartum period, we have an opportunity to really help them change nutritional behaviors and to help them promote an effective weight management and nutritional routine. So it's important to take that opportunity and help your patients. The dietary requirements will go back to pre-pregnancy levels for your moms who decide to formula feed. So making sure that your moms understand the nutritional principles is one thing that's going to help guide your teaching. If your mom has a good understanding of nutritional principles, then you can simply just tell her to reduce her caloric intake by about 300 calories a day, because that is about what you need to sustain you through the antepartum period. But if your mom doesn't really understand calories, if she's young, if she's an adolescent, then you might have to teach her the basic principles related to nutrition. So that would mean things like the importance of a well-balanced diet, how many carbs, how many vegetables, how much protein, how to get those, what types of foods give you those basic building blocks of a diet, how to read nutritional labels. All those things might be something that you have to teach to someone who has a limited amount of knowledge about nutritional principles. Some people might need a referral to a dietitian, particularly if they gained a whole lot of weight during pregnancy. And then teaching mom about the baby's nutritional needs. Since she's going to formula feed, she needs to know how to select a formula. What's a good one? What's the right one for her baby? How do you prepare it? And then do you need to add an extra vitamin or a mineral supplement to that? Those are all things that you would discuss with your mom if she was going to formula feed. On the other hand, if you have patients who are going to breastfeed, their nutritional needs are actually going to increase. So it is very important that they understand the need to consume enough calories to sustain their milk volume. People who do not eat enough or who try to diet and lose weight while they are breastfeeding will have an issue with milk volume supply. The quality of the mom's milk is not going to be affected by how much or how little she eats, but the amount of milk she makes will be affected. So her protein intake should increase. From a pre-pregnancy requirement, your mom should be eating 200 calories more than what she was eating during pregnancy. And then if you were talking about a pre-pregnancy requirement, she should be eating 500 calories over what she was before she was pregnant. So 200 calories more than what she was eating while she was pregnant, and 500 calories over what she was eating before she got pregnant. So we're looking at somewhere, for somebody who's in a normal caloric range, somewhere between 25 and 2,700 calories a day. Protein intake, again, should increase during the first 6 months of breastfeeding, and calcium requirements remain about the same as they are during pregnancy. But liquids are especially important when you're breastfeeding, particularly water, because if you do not stay hydrated, you will not make enough milk. Moms sometimes are often really worried about specific foods whenever they breastfeed, so things that are spicy or broccoli or, things that they think might harm the baby. But really, there aren't any foods that you have to specifically avoid during breastfeeding other than things like alcohol or substances that are harmful, so teratogens, smoking, illicit drugs, those things. But from a food standpoint, there's not really much that you have to avoid while you're breastfeeding, but you just pay attention to how your baby acts after you eat certain foods, and if you notice that certain things you eat bother the baby, then you try to avoid those. All right, so let's talk about psychologic adaptations. So the postpartum period is a major time of readjustment and adaptation for families, particularly the mothers. Mothers will experience a variety of responses as they adjust to this new little baby and how to fit it into the family. There can be also a lot of postpartum discomforts physically that happen. Mentally, there can be discomforts. Because she might experience changes in her body that she doesn't like or she's not used to. And then also this reality of no longer being pregnant will set in. And then a lot of moms will feel very empty, just literally feel very empty and can become sad. The first day or two after birth, the mom might seem very passive and more concerned with her own needs. And that is totally normal. She is fatigued and she's hungry. So food and sleep are kind of her main priority. And she's going to depend on other people to help her care for the baby more than what she normally would. So by the second or the third day, when she seems to kind of have herself together, then she's going to feel ready to resume control of these mothering behaviors, her body, taking care of herself, and just her life in general. Moms who will experience feeding difficulties, in particular, can be at a great risk for anxiety and stress. There is nothing that stresses a mom out more than thinking that she isn't feeding her baby enough, or that her baby is not getting what it needs. And even if there aren't any feeding difficulties happening, just the postpartum period in general, particularly for new moms, can raise lots of anxiety and stress. So these people need a lot of reassurance. There are 3 phases that we really think of when we think of psychological adaptations in postpartum women, and those are the taking in, taking hold, and the letting go phase. So the taking in phase has to do with this reflective and dependent behavior. So the mom's reflecting on her experience during the labor and delivery process. She is focused on herself, really, in the taking in phase. Like we said on the last slide, she might be hungry, she might be tired, and she's dependent on other people to help her take care of herself and take care of the baby. And then she moves into this taking hold stage. This is the teachable stage for moms, because they're ready to accept the responsibility of being a mother. They're ready to accept the responsibility of taking care of themselves, and they are very teachable. They're ready to learn. They're ready to accept. And this is the time whenever you're able to do the most good from an educational standpoint. And then in the third phase, this is called letting go, and they accept their new role as a mom, and they really relinquish this idea of being single. So they know that they have a new responsibility, and they sort of let go of their old life and accept this new role and this new responsibility as a mom. And then we would be be amiss if we did not talk about Miss Ramona Mercer, who is a famous nursing theorist, and her development of this maternal role attainment theory. And basically what Miss Mercer says is that maternal role attainment happens during pregnancy and during the postpartum period, and it is a process by which a woman learns mothering behaviors and then becomes comfortable with her identity as a mother. It occurs every time that a mom bears a new child. And there are 4 stages. So Ramona says that the anticipatory stage occurs during pregnancy. And during this stage, moms look to other people to be role models for their mothering behavior. So they may look at their own moms and say, oh gosh, my mom does all of these things so well, that's how I want to be. Or they may look to a godmother or an aunt or a friend or someone, but they look to other people to seek out characteristics that they like and that they want to be like, that they want to emulate. In the formal stage, this happens when the child is born, and it is influenced by other people. So the mom's actions is guided by what other people expect of her. So for example, if she's a breastfeeding mom and her grandmother comes in and says, oh, that baby is not getting enough to eat, it's hungry, he's crying, he's sucking on his fingers, you need to feed that baby, that milk is too thin, we need to use some rice cereal. And that pressure of those statements cause that mom to be influenced to change her mothering behavior. So she maybe starts to supplement instead of exclusively breastfeed, even though she kind of wanted to exclusively breastfeed. So what other people say and do and suggest in the formal stage will mold the actions of the mom and her mothering behaviors. Then in the informal stage, this starts when the woman starts to make her own choices about mothering. So she might just say, okay, well, I know that this works for me, so that's what I'm going to do, right? So I know that I breastfeed better whenever I'm sitting up in the chair, and I don't need to co-sleep with my baby because I like to get up and sit in the rocking chair and do that in the middle of the night. So she just finds a routine that works for her, and she develops that her own style. In the personal stage, this happens when the woman starts to, or is, not starts to, but she is comfortable with the idea of herself as a mother. So she feels like she's got this in the bag, and she feels good about what she does, and she doesn't care what everybody else thinks. So moving through all these 4 stages will typically take a mom somewhere between 3 and 10 months after birth. And it has a lot to do with who you are, what your social supports are, or what your marital relationship looks like, if you have one, your socioeconomic status. It can have a lot to do with the mom's age, her previous experiences. It can have a lot to do with the baby's temperament. And even with the mom's personality. So is she a positive person? Is she a very driven person? Is she a very pragmatic individual? Is she a kind of a negative Nancy? All of those things will have to do with how well and how quickly she can move through these 4 stages of maternal role attainment. There are several challenges that a mom can face during the postpartum period when it comes to adjusting to her new role as a mother. It is often very difficult for moms to find time for themselves. They may have feelings of incompetence in this new role of being a mom. They might feel like they really don't know what they're doing. Be very questionable about if they're doing things right. They are tired and so fatigued because they're not getting enough sleep. They may have a whole lot of feeling of overwhelming responsibility, and that can be coupled with this sense of loss of freedom that they had before. For moms who have more than one child, they can feel bad that they're not able to spend as much time with the siblings of the new baby, or maybe they're not able to spend as much time with their husband or their other family, and that will start to cause stress and feelings of overwhelming they can become sad about those things, but it does place a lot of stress and burden on moms whenever they start to feel this way. And then also the infant's behavior, particularly around 8 months of age, can have challenges of its own that can affect this maternal role attainment. It is really important that moms can sort of take a self-assessment of who they are and what their personal characteristics are as well, because that can affect their orientation towards the baby. So, for example, the levels of trust that a mom has developed in response to what her life experiences has been. So, did she have a mother that she trusted? Did she have life experiences that lended themselves to be able to allow her to become a trustworthy person, or a person who has a lot of difficulty building trust with people? What is her level of self-esteem? If she has very low self-esteem, it is very likely that she's going to struggle with feeling good as a mother, feeling like she's doing the right thing or that she's doing a good job. What's her capacity for enjoyment, just in general? So again, is she this negative Nancy that is not able to really find the good in situations, but always seeks out the negative? Or is she a bubbly personality who can really find the positive of anything and just sort of lets things roll off of her shoulders when they are negative and just moves on to the next thing? What's her knowledge about childbearing and child rearing? What are her previous experiences and beliefs? So did she have siblings that she took care of growing up? Was she an only child and doesn't have a whole lot of experience with newborns or babies? What's her prevailing mood? What's her usual tone? Her usual personality? Is she an angry person? Is she a depressed person? Is she very sensitive? Is she extremely bubbly? Is she very, by the book or very, very pragmatic? Is she fly by the seat of her pants? All of these things can affect this maternal role attainment. And then, of course, this last one, reactions to the pregnancy. Was it wanted or not? Was it a smooth pregnancy? What were the life events that were surrounding this pregnancy? So is it a mom who's gotten pregnant and now she and her husband are divorced before she's had the baby? Can be a lot of things from a life standpoint that play into how a mom is able to move through these roles. So the development of family attachment. The father of babies typically have a very strong attraction to the newborn, and their feelings are really similar to the mother's feelings, and they start to have this sense of engrossment. They are very absorbed. They are very preoccupied. They have a lot of interest in the newborn, and that usually happens after birth when the father and the newborn can bond. So the dad can hold the baby. He can look in the baby's eyes. There are a lot of differences in involvement when it comes to different types of cultures. So in some cultures, the fathers don't have anything to do with the newborns. So sort of knowing who you're dealing with up front will help you be able to assess this family attachment. Siblings and other people also can develop attachments with the newborn. Babies are capable of attaching themselves to multiple people. So they can have an attachment with a sibling, with a grandparent, with aunts and uncles, and other significant individuals in the family circle. But the social setting of where you are and that individual's personality can affect how these multiple attachments happen, if they happen or if they don't. It's really important to remember that your family-centered care model is key here. In the initial maternal attachment stage, you are going to see certain behaviors that occur. And you'll be able to assess these in the hospital right after birth. And it's really funny to watch these once you understand and know about them. But there is a really regular pattern of maternal behaviors that happen after labor and birth. There's this progression of touching activities that occurs, and it can vary depending on the person from several minutes to even days. So moms rely really heavily on their senses, so sight, touch, hearing, and smell. And in the acquaintance phase, moms and babies both will start to get acquainted with each other. And so in this very initial time where this progression of touching activities happen, what you'll see is the moms kind of reach out and touch the hand and let the baby grip her finger, or she'll touch his toes, or she'll sort of rub his head with her fingertips. And then as she becomes more comfortable, that touch becomes more engrossed, and she will start to increase the proportion of time and the way that she touches the baby. So she'll spend time more in this sort of face-to-face position. We call it in face. And she'll have eye-to-eye contact with the baby. They have a really intense interest in having the newborn's eyes open. They want to look in the baby's eyes. And when they're open, the mom is going to greet, and she's going to talk to the baby in really high-pitched tones. She will respond verbally to any sounds that are emitted by the newborn. And you as the nurse can help to facilitate movement through these activities that help strengthen this attachment and bonding that a mom has with a baby, or a dad, by doing things like dimming the lights in the labor room so that the baby can open its eyes and look at the mom. Maybe even delaying administration of the EES ointment for up to a certain amount of time so that the mom can bond and look in the baby's eyes. Making sure that the bassinet is close by the mom's bed if you leave the room, so that she can respond to any sounds that the newborn has. And your ongoing assessment of her psychologic adaptation as a mom to this newborn is really critical, because we have to be able to evaluate what type of patient teaching is needed so that we can provide the appropriate things. So making sure that the mom knows what she's doing, and keeping an eye on her, because she may not even know that she doesn't know what she's doing. And you assessing that and evaluating that can really shape what your discharge plan is going to look like and what your teaching is going to look like every time you come into the room. Maternal and social role preparation and interactive, being an interactive and therapeutic nurse will have a very positive impact on the progression of how you can teach a mom. So in other words, you developing a therapeutic relationship with your patient is going to go way farther whenever you try to teach her something than if you put her in front of you in a formal setting or a formal role and then try to give her a bunch of directions on what to do. So let's talk about a few more sort of phases that you might see. So there's going to be this acquaintance phase that happens for both the mom and the baby, where they start to get acquainted with each other, and that's going to be all part of this progression of touching activities and holding the baby in face. And then they'll move to this sort of phase of mutual regulation. And there's got to be a balance that happens between the mom and the baby's needs. And sometimes during this phase of mutual regulation, the mom might start to have these negative feelings. And those might just start to bubble up, but they're going to be probably unspoken, because it really is socially unacceptable in most circles to say that you're having negative feelings about your newborn. So in this phase of mutual regulation, the mom and the baby sort of struggle for control. But the goal of what we want to happen is something called reciprocity. So we want this relationship between the mom and the baby to be satisfactory for both of them. So the baby has their needs met and the mom has her needs met. From a lifespan standpoint, postpartum adolescents have a lot of special needs, and they will depend, what those needs are going to depend on their level of maturity and what their support system is. So nurses need to be very cognizant of what the maternal and newborn interactions look like. We have to pay super close attention to adolescents and their bonding behaviors with their baby. What are the roles of the support people who are involved? Are there people who are support people that are involved? What are the plans for discharge? Where's this adolescent going? Who is going to be there to help her? Making sure those people are included in discharge teaching and other teaching throughout the stay. What is their knowledge of child rearing? Are they an adolescent who helped to raise siblings? Are they an adolescent who has no clue? And then what are the plans for follow-up care? Because it's really important that adolescents have a very specific plan of care dealing with just follow-up. Contraceptive counseling is key for adolescents and needs to be a big part of the patient teaching. And then how you as the nurse handle the newborn in front of an adolescent is going to be a role model for that adolescent and how she develops her mothering behaviors. So whether or not you realize it, what you do in the room in front of the mom is going to teach her a lot about what she needs to do and what's normal. A normal way to touch the baby, a normal way to swaddle the baby, a normal way to change a diaper. She's gonna see you do these things and take them in, even if you're not actually teaching. Doing your newborn exam at the bedside and explaining things to her as you go over the newborn's body and talking about the cord and fontanelles and all those things can give them so much information about the baby's health, and showing them positions for how to handle the baby. That is really important. Something so simple, but something that adolescents might not understand. Praise and encouragement are going to be very important to helping increase their confidence. They probably already have some self-esteem things that could be going on. They're already questioning themselves about what kind of mother they're going to be. They may feel very overwhelmed and very stressed. So choosing things that you see that they are doing good and giving them praise for those will go a long way in increasing their confidence. And then obviously when you see things that they're not doing right, finding a way to show them how to do those things correctly. Group classes can be really important for adolescents as well, because it can help teach them skills and address their needs from an adolescent standpoint. And typically there are people who are around their same age in some of these classes. So if you can find one that is specifically for adolescents, that can be really helpful. Postpartum moms who are over the age of 35 are typically better prepared for parenthood because they've had a whole lot of life experiences and typically are fairly well educated. But older couples can oftentimes be very overwhelmed because the newborn will alter what their established routines and their practices are. People over 35 tend to get very set in their ways. And if they have never had children and if this is a first child, it can be a real shock to them about really how much it's going to change their routines and their practices that they have enjoyed for so long. Women who have pre-existing conditions or complications might also need additional follow-up with other healthcare providers besides their obstetrician. So you as the nurse might have to be setting up those appointments with other people if they have chronic conditions. And I believe we will stop there, and we'll record the rest of this at I'll record the second half of this at another time. Thanks for watching.